Hi, my name is Elise Omaki, and I'm a senior research associate with the Johns Hopkins Center for Injury Research and Policy. Today, I'm going to talk about a program called Safety in Seconds, which is a mobile app for parents of young children that delivers tailored education about injury prevention. So, motor vehicle crashes are a leading cause of death for children in the United States. Among children 5 to 9 years old, this is the leading cause of injury death. Among children 1 to 4 years old, it's the second leading cause of injury death. We know that child passenger restraints, things like car seats and booster seats, are really effective at reducing injury and death due to car crashes. But national estimates suggest that almost half of children who are 4 to 7 years old and should be in a car seat or booster seat are instead using a seatbelt or are unrestrained entirely. Among American Indian and Alaska Native children, we see an increased risk of death due to car crashes. For children 1 to 4 years old, the rate of death is about 1.5 times higher than the national average. And among children 5 to 9 years old, the rate of death is almost twice as high as the national average. We also see disparities in non-fatal injuries due to car crashes for Native American and Alaska Native children. And so this is a really important issue for this population. Research has demonstrated that car seats and booster seats are effective at reducing the risk of death to children in the event of a car crash. For young children, experts recommend that they are buckled up in a child safety seat. As children start to outgrow their safety seat, but they're not yet big enough for a seat belt, experts recommend that they use a booster seat instead. Booster seats can reduce the risk of serious injury by 45% than compared to using a seatbelt alone. Despite their effectiveness, car seats, and especially booster seats, are really underutilized by families. To address this, my team created a program called Safety in Seconds. The original Safety in Seconds was a computer kiosk, like what's pictured on the screen, that was stationed in the pediatric emergency room. Uh, at the time, this was before mobile phones were widespread. And so when parents brought their children into the emergency room, they could engage with the computer and learn more about child safety. They would take a 20-minute assessment about car seats, fire safety, and poison storage. And then they would get a printed report with educational information that's tailored to their specific situation. This particular study revealed that it is feasible to use computer technology to deliver patient education in the emergency room. As technology has changed, we also have needed to update the Safety in Seconds program. As we were launching a recent update, we wanted to figure out what is the current landscape of computer-based injury prevention programs. And so we did a systematic review. At the time of the review, we found that there were 44 research studies that had used computer-based programs for injury prevention education, only 2 of which at the time were mobile technology or portable devices. Aside from that, we found plenty of apps in the App Store that were freely available that were focused on educating parents about child safety, but none of them had been rigorously evaluated for impact. So for this latest study, what we call Safety in Seconds 2.0, we set out to evaluate a smartphone app on parents' child passenger safety knowledge and behaviors. The program is driven by a pair of health behavior theories. First, the elaboration likelihood model says that people are more likely to process information if they feel that it's relevant to them personally. Um, and this is the idea behind tailored education, that a message crafted specifically for a specific individual based on their own characteristics is more likely to be remembered and acted upon. The second theory that we used was the precaution adoption process model. And this is a theory of behavior change that describes how people will pass through various stages when making a decision about a health behavior. In this particular theory, there are 7 different stages, ranging from being unaware of a health behavior all the way up through someone who is actively maintaining a health behavior. When we started building the new Safety in Seconds platform, we continued to use a 20-minute assessment on child passenger safety. And we split the child passenger safety behavior into 4 discrete behaviors: using the correct car seat based on the child's age and size, having the child ride in the back seat, being buckled up on every ride, and having the car seat inspected by a car seat expert. Um, as people went through the assessment, the computer would collect the responses and then use those responses to generate a feedback report that scored each of the 4 behaviors and provided a really detailed educational messaging based on their responses. We also had a parent portal that had links with additional information and resources for families. We used a template to help determine the structure and content of each of the tailored messages. So the messages were organized in a message library, and then the computer algorithm would determine which content to deliver based on the parents' responses to the questions. These questions were things like self-efficacy, social influence, risk perceptions, and what their barriers were to addressing the health behavior being asked of. The app was tested in a randomized controlled trial. We recruited parents from the pediatric emergency room at Johns Hopkins Hospital, as well as Arkansas Children's Hospital. In order to participate in the study, parents needed to have a child between the ages of 4 to 7 years old, and they had to drive with the child at least once per week in a car that they owned, borrowed, or would get a ride in both ways. Parents were randomly assigned to receive information either about child passenger safety, which we call our intervention group, or about home fire safety, which we call our control group. Parents would download the app onto their phone and then go through that 20-minute assessment and receive the tailored education and reports right there on their own phone. We conducted a follow-up survey 3 months and 6 months after their initial visit to the emergency room, where we asked about those 4 car seat behaviors: using the right type of car seat for the child's age and size, if they were riding in the back seat, if the child was buckled up every time, and if the seat had been inspected by a child passenger safety expert. And over the course of our study, we enrolled 1,129 families. About half were randomized to that intervention group and received car seat safety information. The other half were randomized to the control group and received home fire safety information. And at the end of the study, we had 742 of our enrolled families who had completed that 6-month follow-up survey. So this is a table that describes the characteristics of our study sample. You can see that the mean age in both groups was about 32 years old, and most of our participants were female, majority Black or African American. And we had similar distributions across the intervention and control groups of education, household income, and homeowner status. This next set of results will show the different car seat behaviors across the study groups for each of the follow-up visits. So the first graph there on the left is looking at the correct type of car seat for the child's age and size. And we can see that at baseline, 69% of our intervention families were using the right type of seat. That increased up to 78% at 3 months and was maintained by 77% of families at 6 months. In our control group, 72% of families were reporting using the correct type of car seat at baseline. That decreased at 3 months to 67% of families, and then came back slightly to 70% of families reporting the correct type of car seat at 6 months. For using the back seat, we saw our intervention group that 92% of parents reported their child used the back seat, and that increased to 95% at 3 months and 6 months. The control group, 90% of parents reported using the back seat at baseline, and that increased slightly to 92% at 6 months. For being buckled on every ride, the intervention group started at 90% at baseline and stayed about the same over time. Our control group started at 83% and increased to about 90% by the end of the study. When we asked if parents had ever had their child's seat inspected by a car seat expert, only 6% of the intervention group had reported such a behavior at baseline, but that increased to 29% at 3 months and 35% at 6 months. We also saw some increases in this behavior for the control group. When we aggregated all 4 behaviors into a single score, we saw that the intervention group had 6% of our families reporting doing all 4 behaviors. And this increased to 27% of families at 3 months and 33% of families at 6 months. In the control group, we also see increases over time, although these increases were not as high as the increase we saw in the intervention group. In order to see the effect of the intervention while controlling for the baseline behaviors, we ran a conditional logistic regression. We used a propensity matching on the likelihood that the family would remain in the study, and this was modeled on several demographic characteristics. What we found is that at 3 months, parents in the intervention group were more likely than parents in the control group to report using the car seat, that their child was riding in the back seat, and that their seat had been inspected by a car seat expert. Intervention group parents also had about twice the odds of reporting all 4 car seat safety behaviors in the control group at 3 months, and this effect was maintained at the 6-month follow-up visit. Taken together, our results suggest that a smartphone app can be an effective way to deliver tailored education to parents about child passenger safety and injury prevention. We're in the process of developing the next iteration of the app with additional content about infant safe sleep and falls prevention, so stay tuned for updates. Thank you.